I'll invite Dr. Neha, a very intelligent, upcoming oculoplastic surgeon. And she is trained from LV Prasad, and she's going to start the session as an opening batsman in the eyelid session of oculoplasty. Over to you, Dr. Neha.
Good morning, everyone. Apologies for the technical glitch. So today I'm going to be speaking about eyelid malpositions and their management. I am Dr. Neha Ghosh, and I've, as of recently, taken charge of the ophthalmic plastic surgery service at Sushila Netralaya. But all of my patients and cases that we will be discussing henceforth is from my parent institute, LVPEI. So eyelid malpositions can range from anything between ptosis, entropion, ectropions, eyelid retractions, and even more complex cases such as anophthalmic eyelid malpositions and traumatic eyelid malpositions. So briefly and in short, this is the cross-section of the lower eyelid. As we know, it is made up of 3 lamella. The anterior lamella is made up of the orbicularis muscle and skin. The middle lamella is made up of the orbital septum, orbital fat, and lower lid retractors. And the posterior lamella is made up of the conjunctiva and the inferior tarsus. And it is extremely important to understand which part of which lamella is actually involved in any malposition so that we can adequately address it. So ectropions can be classified into congenital and acquired types. Congenital is extremely rare. Acquired may be involutional, cicatricial, paralytic, and mechanical. Similarly, entropions can be classified into congenital, involutional, cicatricial, and spastic entropions. So involutional ectropion can vary in their severity. They may either be punctal, they may be medial ectropions without horizontal eyelid laxity. They may have horizontal eyelid laxity. Medial ectropions with MCT laxity. The whole length of the lower eyelid may be involved, and there may even be complete tarsal ectropion. Coming to the more difficult cases, which are cicatricial ectropions, these are characterized by vertical shortening and or scarring of the anterior lamella of the eyelid. They are caused due to thermal or chemical burns, mechanical or surgical trauma, sun damage, or even chronic inflammation. They lead to lag of ophthalmos, which ultimately leads to exposure keratopathy. They may lead to dry eye, infective keratitis, or perforations. The management options of cicatricial ectropion range from myocutaneous flaps to full thickness skin grafts, and may even involve other procedures such as canthopexis, retractor-plication, Z-plasties, and even fillers. So the advantages of myocutaneous flaps over skin grafts are they have a better color and texture match due to local origin. They have less postoperative contraction, and they are cosmetically superior because they follow the relaxed skin tension lines. In contrast, full thickness skin grafts have a likelihood of mismatched texture, thickness, and skin color. There may even be graft infection or necrosis, and the chances of recurrence are high, up to 44%. However, there is nearly 100% graft viability in this area. This is a case of a 53-year-old gentleman who had a history of blast injury to the face 4 months prior to presentation. He had difficulty closing eyes, and he had watering since the past 4 months. So he had skin hypopigmentation, scarring, bilateral shortening of the anterior lamellae, bilateral cicatricial ectropion with complete lower eyelid tarsal eversion, and right medial canthal webbing and bilateral loss of eyebrow hair. He also had significant lag of ophthalmos on both sides. The surgical plan was ectropion correction with full thickness skin grafting. And these are the steps: subciliary incision along the length of the eyelid, dissection of the cicatricial bands, retroauricular skin harvesting. We can take skin from anywhere, such as preauricular, supraclavicular, upper arm, or even the opposite eyelid. Graft was sutured to the defect and then divided between the upper and lower eyelids, and then quilting sutures were taken to adhere the graft onto the underlying tissues. This was the appearance on postoperative day 1. Both the wounds were healthy, and at postoperative 2 months of both sides, there was no lag of ophthalmos. And we can see at 4 months postoperative, there was no lag of ophthalmos, improved corneal clarity, and the conjunctiva was quiet. So from this case, we can glean that full thickness skin grafts are useful when surrounding eyelid skin is unhealthy or scarred, and it is effective for 4 lid cicatricial ectropions, such as in these cases, and there is good graft uptake due to sufficient periocular vascularity and small size of the graft. Similarly, in cicatricial ectropion in an anophthalmic socket, this was a case where we did a monopedicle flap, and the patient did well, and a very good contour of the lateral canthus. In anophthalmic syndrome, we have a series of conditions where there is enophthalmos, superior sulcus depression, lower lid retraction, and upper lid ptosis. So in these cases, how do we correct them? There are non-surgical options as well as surgical options. Non-surgical options basically involves adjusting or just modifying the custom ocular prosthesis by placing a bulge at the upper anterior surface to support and increase the height of the upper eyelid. And the extra volume in the upper anterior part and less bulk in lower part also makes the prosthesis tilt forward, thus correcting the upward gaze and improving the aesthetic appearance. We also make it less bulky so that it eliminates the downward and forward thrust and corrects the lower lid ectropion. And a small extension made anteriorly on the inferior part pushes the tarsal plate upwards, so it also reduces lower lid retraction. Surgical options may include fascial slings with or without horizontal lid shortening, lateral tarsal strips, and retractor release and spacer insertions in these cases, such as cartilage, sclera, hard palate, mucosa. Now coming to the entropion, this is a simple case of an involutional entropion. We treated her with a Jones procedure and she did well. If there is too much eyelid laxity, then we can combine it with a lateral tarsal strip, which decreases the chances of recurrence. Now, this is a case which is a very difficult case to treat, intractable, and has a high rate of recurrent cicatricial entropions, where we can see she also has a whole row of distichiatic lashes, more on the right side than on the left, rubbing on the ocular surface. So here we had done an anterior lamellar repositioning, and we also did electroepilation of the distichiatic lashes, and she did relatively well. But these cases are known to cause a lot of recurrence. This was a young boy who had a carbide injury, chemical blast injury, which left him with a cicatricial entropion as well as shortening of the upper lid. So in this case, we had to not only divide the anterior and posterior lamella, but also place a mucous membrane graft and also do a LPS recession to lengthen the medial aspect of the upper lid. So I'll just come to some quick points to remember in ptosis. This is a child with a this is a young girl with a left mild ptosis, and we had planned her for Muller's muscle conjunctival resection, and who is a good candidate for an MMCR. So someone who has mild ptosis, who has a positive phenylephrine test, and also who has a faint lid crease on the contralateral side, so that we don't actually have to go onto the skin at all, and we can just resect the Muller's muscle, and she has, and the post-phenylephrine appearance is an indicator of how she would look after MMCR. So in this patient, this patient had severe ptosis on the right side, and she also had mild ptosis on the left side. We had corrected, she only wanted ptosis correction on the right side. We corrected her ptosis, but this led to the ptosis becoming more pronounced on the left side. So we also have to take into account Herring's law prior to addressing ptosis on one side in such patients. So, and we have to counsel them appropriately that maybe they might have to undergo the correction on the other side as well. So again, if you have severe ptosis on both sides, of course, we can address it together. Sometimes patients want that, but it's always better to do a sequential correction in bilateral ptosis for ideal titration of the endpoint. Tarsal platform show, I'll just quickly finish. Tarsal platform show is cosmetically more significant than the actual palpable fissure height, as we can see in this patient, because even though we corrected the ptosis on the left side, you can see that there is still an increased tarsal platform show on the left side, which the patient was concerned about, and it made her feel that the ptosis was not adequately corrected, even though the palpable fissure height that you can see is exactly the same on both sides post-surgery. So this is a patient of CPEO. I won't go into that, but again, similarly, this is a patient who also had moderate to severe degree of ptosis with extraocular movement limitation resembling CPEO. But we have to make sure that we do ISPAC tests in all of these cases. The sensitivity is about 86% and specificity is about 79%, and the specificity and sensitivity of ISPAC is very similar to single fiber EMG. So we should definitely go ahead and do that, and they also have a high negative predictive value. And this is a patient with a positive fatigue test. So in any of these cases, if there is any amount of doubt, it's always a good idea to go ahead with a diagnostic trial of pyridostigmine, which is considered safe and also resource efficient. Because we have run out of time, I will end the session now. And thank you so much for your patient listening.
Okay, so do we have time for questions, or should
So
we?
we'll
I
do
think
the
we can
discussion
do it
later.
alongside, right? No?
Later, so we have time for panel discussion.
Okay,
Yeah,
that's
we'll
good.
continue.
All right, that was a good presentation, and we are getting so super specialized. We have a session on eyelids, and maybe next year we'll have one on the upper lid and the one on the lower lid. So let's, hope for more super specialization. That's good. Thank you. Would you like to join us on the dais, Dr. Fairuz? Yeah, come. No? Okay.
We'll call upon the next speaker,
Thank you.
Ms. Dr. Joyita Das, eyelid reconstruction, VAST.
Good morning, everybody. Thank you, AIOC Scientific Committee, especially Dr. Fairuz, for the kind invitation. I'll be talking on eyelid reconstruction. So, as we all know that eyelid reconstruction is a challenging task to all plastic surgeons, specifically because of its dynamic complexity nature of the eyelid. It's playing a role of glow protection, maintains the integrity of ocular surface and tear film, and it also has role in lacrimal pump and expression of beauty. So knowledge of basic anatomy is very essential for proper reconstruction of the eyelid. The eyelid is an elliptical structure with a horizontal fissure height of fissure length is 25 to 30 millimeter, and the vertical palpable fissure height is around 8 to 10 millimeter. Lateral canthus is around 2 millimeter higher than the medial canthus. For the purpose of reconstruction, the eyelid is grossly divided into two lamella: anterior lamella formed by skin and orbicularis muscle, and the posterior lamella formed by tarsal plate and the conjunctiva. And there is a structure called gray line, which is the junction between these two lamellae. Another important thing is relief skin tension line, which is also known as Langer's line. This is the muscle tensile line, and the importance of this are, if we give a incision along the or parallel to this Langer's line, there will be minimum scar. And when there is large tissue gap, the suture closing should be tangential or oblique to the Langer's line. The indication of eyelid reconstruction are congenital, that is coloboma is the most common. Among the acquired cause, primary reconstruction after tumor surgery, trauma, and secondary reconstruction after complicated previous surgery, burns, and radiation. Whenever we are planning for a lid reconstruction, we maintain some of the goals are preserving the eyelid function to develop a stable eyelid margin. We should ensure adequate eyelid closure for ocular protection, maintaining adequate vertical lid height, and the most important is creating a smooth epithelialized internal surface, and also we should maximize the symmetry and cosmesis. The principle of eyelid reconstruction first is, if we are planning for reconstruction of the full thickness lid defect, that is both anterior and posterior lamella is absent, then if we use graft for one lamella, then other lamella should be the flap, that is it should have its own blood supply. Here you can see the example, the posterior lamella has been grafted from the other lid tarsoconjunctiva, and the anterior lamella is formed by pedicle graft. The other principle are, you should maintain a sufficient canthal fixation. We should match the tissue, similar color and thickness. And if we are planning for skin grafting, first we should minimize the defect area as much as possible before sizing a graft. In the assessment of lid defect, what you should see, this is the full thickness or partial thickness, lid margin involvement, size, location of the defect, canthal involvement is there or not, canaliculi status, and of course the age of the patient or the lid laxity. The management algorithm are, if only the anterior lamella is affected, then direct closure, lesion sphere, that is healing by secondary intention, local flap like VY flap, bilobe or rhomboid flap, or if it is a big one, then skin grafting can be done. And if it is the marginal or full thickness defect, then size of the defect plays the role. If it is a small defect of 25 to 50%, then direct closure plus minus canthoplasty. If it is a medial defect that is 50 to 75%, then Tangell's flap and McGregor flaps play the role. And if the large defect that is more than 75%, then if it is in the upper lid, then Cutler-Beard flap, Mastery switch flap, or globular flap is the choice of flap. And if it is in the lower lid, then Hughes flap, Mastery cheek rotation flap option is there. And there are some specialized flap called Frique, paramedian, and tripier flap. These can be used in both upper and the lower lid. This is one example of direct closure used in upper only anterior lamellar defect repair. This is pair that is healing by secondary intention. Eyelid has a very peculiar, unique property that it has a very good blood supply and it can heal the defect automatically, but it takes some time. This is an example of upper lid full thickness skin graft in a case of pilomatrixoma. And there are also option of PUI, rhomboid, and bilobe flap. This is an example of one of my patients. I did done rhomboid flap in this case. So this is a short, now come to the full thickness margin defect. If it is a small, that is 25 to 50%, then direct closure can be done. First, horizontal mattress, vertical mattress suture is given in 3 millimeter rule. Then the suture is tight and keep it long. Rest of the sutures are given muscle and the tarsal plate is sutured by interrupted suture by 6-0 Vicryl. And finally, the long end of the suture is tied with the interrupted suture for avoiding corneal trauma. Next, come to the medium-sized defect. Tangell semicircular flap is the option. Here, this is a short video of the procedure. This is a case of a golden hair syndrome, and this is a wedge size flap has been present. Next, lateral canthoplasty is done. Lateral canthus upper arm is cut, and then a small semicircular myocutaneous flap has been dissected. Now the suture is as the direct one. Vertical mattress suture. And finally, the lateral canthoplasty and the muscular flap has been sutured in interrupted suture. This is the case of this. This is the case I've just done now. This is the 2 weeks of post-op follow-up. Next is if it is a more than 75% defect. If it is upper lid, Cutler-Beard is the option. That is the full thickness flap from the lower lid. This is the short video clippings of the same. First, after taking the malignant tumor along, after taking the frozen section, the defect has been closed from the full thickness myocutaneous flap from the lower lid. The full thickness flap has been made. And two lamellars are divided first. The posterior lamella then advanced and suture with the upper end of the defect. And we should also take care to tie the LPS muscle along with the graft, and the skin muscle has been tied accordingly. After 6 weeks, the flap is divided. This is the pre and post-op result of the same. And this is another less commonly used technique. Less commonly used technique, that is Mastery switch flap. It is used in various, it is less commonly used. And this is the pre-operative and the post-operative picture of this procedure. Next is, if it is lower lid, more than 75% defect, you can do a Hughes flap, that is upper lid tarsoconjunctival flap, shifted to the lower lid, and the anterior lamella is anterior lamella formed by either free skin graft or pedicle graft from the upper lid. This is a short video clipping of the Hughes flap. First, after taking the tumor dissection, this is the gap defect. And after margin clearance, the defect is measured and replicated in the upper lid tarsal plate after keeping that 5 millimeter marginal gap to maintain the upper lid stability. This is the tarsoconjunctival graft. Up to molars and muscle, we have to dissect it out, and it is advanced posterior downwards and suture with the remaining end of the tarsal plate of the lower lid. Then from the cheek, skin muscle advancement flap has been taken. This is the Barrow's triangle we are drawing. Okay, just last minute. And it is advanced to form the anterior lamella of the newly formed lid. Good. This is the pre and post-operative picture of this patient. There are some specialized graft called glabellar flap, which can be used in both used in upper lid reconstruction. The nasojugal flap, which are to fill the defect of the medial lower lid defect. This is the pre and post-op picture of this face. So the clinic pearls from this presentation are, the eyelid reconstruction is one of the more challenging areas of the face to reconstruct because of its dynamic complexity. And when approaching lid reconstruction, a thorough understanding of the surgical anatomy is very important for planning a successful surgical approach. And selection of appropriate eyelid reconstruction depends on patient age, comorbidities, eyelid condition, defect size and position, and of course, surgeon expertise and preference. Thank you for your present hearing.
Thank you, Dr. Joyita. Now we are waiting for this particular talk by Dr. Francesco Leoni. We welcome him for his talk.
So while Dr. Leoni is taking his place on the dais, on the stage, I just want to say that eyelid reconstruction, it's a very, like the lid is a very forgiving structure, especially in elderly people. So there are a host of procedures. You can devise your own procedure if you want to find a place in history. It'll come down with your name. And net, if you want to just have 4 guiding principles that try to do a primary repair or try to mobilize tissue from primary repair along with the same lid. And then if you can't do that, then do a lid sharing procedure. And number 4, if you can't achieve that too, you can get a graft from a distant place. And so it's very simple. I mean, there are just 4 or 5 guiding principles. And thirdly, always have plan A when you're going to take the patient to the OT, but always do have a backup plan also, because you may not be able to fit in your procedure into that case. So that you should have another plan that is, okay, I'll do this, but if I can't do it this way, I'll then switch over to another technique. And then sometimes you can combine 2 techniques also, like techniques, Cutler beard along with the lateral advancement or something. So Dr. Leoni, sorry to keep you waiting. Please go.
Okay, thank you, sir.
Carry on.
Thank you very much to all of you. It's a great pleasure and an honor to be here. So my talk is on congenital blepharoptosis, and we all know there are lots of controversies on congenital ptosis, so I'll try to focus on the 5 most important ones. So first, the timing of surgery. When do we operate on these children? Second, the choice of operation. Is there a best operation for any of these children? 3, do we change our surgical option if we are in front of uni or bilateral ptosis? 4, which is the best choice in Marcos-Gangio-Winking ptosis? And finally, is it better a one-step or a multi-step surgery when we have ptosis and squint at the same time? So first, the timing of surgery in unilateral congenital ptosis. So we know that there is a difference between these 2 children. On the left-hand side, you see a 12-month-old little girl, and it's already too late to operate on her when you have amblyogenic ptosis. And there is a difference on the boy on the left-hand side, because you see there is an anomalous head position, which is suggestive of well-preserved binocular single vision, so we can wait a little bit more time. So for the first case, what we have to do is to operate possibly in the first 3 months of life, and the best options, in my opinion, is still unilateral brow suspensions with known autogenous, known integrable material. We have to overcorrect the eyelid a little bit, as you see in this case. We have to tell the parents of the patient, this is not cosmetic surgery, this is pure functional surgery. We have to preserve the sight of the patient. This is an anti-amblyogenic correction of ptosis, and so we gain time until the child is a little bit older to do definitive surgery at another stage. What is a relatively new concept of the last 5 to 10 years is that even in mild cases of unilateral ptosis, like in this child, we might have anisometropia, regional myopia, and amblyopia that may be not initially apparent, but they progressively develop during follow-up. And what is even more important, they may regress following surgical treatment. And this is the reason why recently, for unilateral congenital ptosis, we started to operate a little bit earlier than usual. And we reviewed our cases recently, and we found out that the best results were when we operate these children between the age of 2 and 4, which is A plus B, as opposed to children older than 4, C, D, and E. So the results were significantly better, both in terms of functional result, cosmetic result, and decrease of postoperative lag of thalamus. And we see some of our results. So this child was age 2, 3, 2, 3.5. And we went a little bit further, and progressively we start to study the muscle, so the quality of the specimen of the levator muscle we excised, we resected the surgery. And we found out that when the children were very young, the muscle might be very thin, but there was just a little tiny degree of fibrosis, as opposed to older children where we either have very thin muscles or very thick muscles with fatty degenerations and lot of fibrosis. So the choice of operation. Is there any room for Mueller's muscle resection in children? There is, if you see a youngster, a teenager who had a congenital ptosis and there is a positive phenylephrine test. In this case, of course, you can use Mueller's muscle resection. And again, aponeurosis surgery. This is good when you have a true blepharochalasis syndrome. And my advice is to perform bilateral surgery and to operate these teenagers quite young to obtain symmetry and good results. Posterior levatorpexy was suggested by my friend Ramon Malhotra for any kind of levator function. In my opinion and in my hands, it's quite good when you have a reasonable degree of levator function and you want to operate on oriental children to get a very soft skin crease, like in this case. And the other two types of operations, brow suspensions and frontalis flap, let me introduce the third controversies. So do you have another option when you have bilateral ptosis? In my opinion, frontalis suspension and frontalis flap are very good for bilateral ptosis. I avoid, unless exceptions, this kind of surgery of unilateral ptosis because you have very bad asymmetry in down gaze. But whenever you have bilateral ptosis, the best option is still probably brow suspensions with autogenous fascia lata, or more recently, frontalis flap surgery. We all know that even if you are an excellent surgeon, you might end up with a bad scar on your leg. This is just what happens if you harvest autogenous fascia lata. So another option might be donor fascia, which can obtain very easily in Italy. And in my experience, long-term results are exactly the same if you use donor fascia or autogenous fascia lata. So no big differences. And so for controversies, which is the best option in Marcus Ganjo winking ptosis? So probably you do nothing if there is mild ptosis or no ptosis and mild jaw winking. No treatment is needed. What would you do if there is a reasonable ptosis and there is an evident jaw winking like in this case, then you can ignore jaw winking. You just advance the aponeurosis. This is what you get. And of course, you have to tell this young patient in his early 30s that the jaw winking will get worse following a treatment. So this is the jaw winking following treatment. This is what it was before, but the patient will be happy with its ptosis correction and will just avoid crunchy food in front of his partners. Please avoid levator resection because this is very bad, that gives bad results. If you have evident ptosis and evident jaw winking, then you have to go for bilateral treatment with autogenous fascia lata, but the levator excision might be effective even if you do it only on the affected side. Any space for unilateral treatment, this is accepted and suggested when you have associated anomalies of the affected eye, like in this case. This was a spontaneous perforation, so what we did, it was evisceration ball implant, autogenous fascia lata harvesting, and ptosis correction, and results are good even after some 10 years. And for unilateral cases, frontalis flap might be an option because in my experience, asymmetry is down gaze is better than when you do unilateral brow suspension, like in this case. What you do if you have associated strabismus and ptosis at the same time? Can you do it together? You can. If you do an up procedure, you save time and you avoid exposure to repeated GAs. So in the end, please treat early. Prefer unilateral levator resection in unilateral ptosis before the age of 4. Brow suspension or frontalis flap surgery in bilateral ptosis. Brow suspension in unilateral ptosis only for temporary correction in the first months of life. Frontalis flap in unilateral ptosis, best options. Third nerve palsy with no residual levator function, or Marcus-Gann jaw winking syndrome if bilateral treatment is refused. Thank you very much for your attention.
Thank you, Dr. Leone. I call upon Dr. Ferouz for her speech on eyelid tumors and management strategies.
Thank you, Dr. Neha, and good morning to everyone. The speaker is supposed to be Dr. Mukesh Sharma. He's on ptosis. His flight is delayed. He's on the way, so that's why I'm going ahead. Yeah, thank you very much. It's a pleasure to be here. Can I have my presentation on, please? All right. Yeah, so I'm just going to take you through eyelid tumors management strategies. These are my affiliation and my financial disclosure. So we all know that there is array of eyelid tumors. It could be benign eyelid tumors. It could be an inflammation, which can be simulating a tumor. Malignant eyelid tumors, we have the list of it, and we have lethal eyelid tumors. So the management strategies depends upon your clinical diagnosis and what kind of tumors that you're dealing with. So most importantly in eyelid tumors, you need to differentiate. You need to know the differentiating features between a benign tumor and a malignant tumor. And these are the red flags. If there is a rapid growth, if it's firm in consistency, nodularity, ulceration, lash loss, intrinsic vessels, feeder vessels, and regional lymph nodes. So when you are sure clinically that this is what you're dealing with, then you plan your management strategies. As far as benign tumors are considered as kissing nevers, it's mainly cosmetic benefit for the patient, of course therapeutic as well, and diagnostic. So this is a kissing nevers which was excised by stripping and shaving of the upper lid and the lower lid. You have this seborrheic keratosis of the upper lid, where total excision biopsy was done, skin graft and blepharoplasty from the other side for the skin graft was done. This is neurofibroma, localized neurofibroma, where a right eye, forehead, total excision biopsy with skin graft, and also she needed a levator palpebrae superioris resection. So these are benign tumors. It's mainly cosmetic that you're dealing with, all right? Xanthelasma, the patient I did blepharoplasty for both the eyes, which cosmetically enhanced his look also for the xanthelasma of the left eye. Now, we do have these vascular tumors where we can treat conservatively, even without surgeries, as in this case of oral propranolol in a capillary hemangioma with topical timolol maleate. And this is a case of an eyelid varix. All right, a venous malformation where an intralesional injection of bleomycin, one session was given, and the entire lesion regressed. Now, coming to the malignant lesions, it is so very important. That's when I wear the hat of an ocular oncologist rather than an oculoplastic surgeon. Because principles of oncology is very, very important. And why is it so important? It is related to the outcome in terms of recurrence, in terms of mortality and morbidity of these patients. In fact, you have these lethal tumors which can have regional and lymph node metastasis and systemic metastasis. So what is the principles of surgical management in malignancy? You need to have the complete extirpation of the tumor, intraoperative margin clearance, pathological confirmation of the diagnosis, and in fact, after the pathological confirmation, if you need any adjuvant treatment, you should be in par with it. So that is why malignant eyelid tumors are so very different and has to be dealt differently. Now, as far as the primary surgical excision, this is what I do in my practice, and I'm sure all the oculoplastic surgeon, eyelid surgeons, and ocular oncologists do the same. We go for margin clearance. Clinically, we assess the margin intraoperatively, 4 millimeters on either side, lateral, medial, inferior, and also the posterior lamella, as you can see here, is excised. So there are two ways of assessing the margin control. One is frozen section. That's what I do in my practice because I'm not a Mohs surgeon, and also Mohs micrographic surgery. Now, this is a small lesion of sebaceous gland carcinoma, right upper lid, excised, margin clearance, direct repair. We can also have larger lesion, okay? This is a patient with lower and upper eyelid sebaceous gland carcinoma, both went for margin clearance, and this is how he looks like after reconstruction and follow-up, no recurrence. Now, the question of map biopsy in sebaceous gland carcinoma, you can have a nodular lesion or you can have a diffuse pegytoid spread. So when you have a nodular lesion in the eyelid and you have these diffuse conjunctival congestion, it is so very important to also assess pegytoid spread in the conjunctiva with the map biopsy, and these are the representative areas from the bulbar conjunctiva, the tarsal conjunctiva, and the fornix, and this is how many lesions, almost 17 to 18 2 into 2 millimeter lesions are taken out and sent for map biopsy. Now, when you have a large lesion like this, as a surgeon, as an ocular oncologist, I want a margin clearance after excision. So what I do is I chemo-reduce it. I give chemotherapy initially, chemo-reduce it to an extent when now I can excise it with a margin clearance. Now, certain things are very patient-specific. So this old man, gentleman, he's 85-year-old. So he was not fit for chemotherapy because of his renal function and his liver function status. So the only option that I had in this malignancy, it was a squamous cell carcinoma, was to give a stereotactic radiation. So this is how he presented. This is actually after 2 months of stereotactic radiation, where the tumor has completely regressed. Now, exentration, yes, we barely use it now because we have so many armamentarium where we are trying to preserve the globe and the vision, but well, in certain situation, you go for a exentration and orbital extension and diffuse pegytoid spread, and well, make sure that we cosmetically rehabilitate these patients. Now we are into an advanced era of biologics. So this was the first drug which came up as a targeted therapy in periocular and eyelid malignancies, the hedgehog inhibitor pathway inhibitor, that is vismodegib, and basal cell carcinoma was a tumor which was initially treated with. Then we saw many other checkpoint inhibitors and biologics, and this is the epidermal growth factor receptor inhibitor targeted therapy with erlotinib, afatinib, cetuximab, ABS, MABS, where targeted therapy is done in order to treat squamous cell carcinoma. So this is, I don't have any personal experience in India with this, but these are, this is from MD Anderson, Dr. Beta Ismaili's patient, where they have tried epidermal growth factor receptors. So we have various other checkpoint inhibitors which has come into vogue for eyelid melanomas, cutaneous melanomas, CTLA4 inhibitors, PD-L1 inhibitors, PD-L1. So these are many, again, monoclonal antibodies which has come up as targeted therapies. Now, going on to the last one, what is the indication of sentinel lymph node biopsy in the management protocol? Yes, it is indicated, where the indication accounts to common cutaneous eyelid melanomas of more than 1 millimeters, sebaceous gland carcinoma of more than 10 millimeters, and Merkel cell carcinoma, which is the lethalist of the eyelid tumor of any size. We do the sentinel lymph node biopsy, where technetium-99 dye is injected into the medial canthus, and then with the gamma probe we assess whether there is any take-up in the sentinel lymph node, and then a biopsy is done. Now, positron emission tomography is definitely done in lethal eyelid malignancy in order to assess systemic metastasis, and possibly this would be the criteria for the positron emission tomography PET scan in eyelid tumors. So to conclude, oncological principles is very important to follow, especially in the malignant eyelid tumors with a primary wide surgical excision. So surgical protocols, applying surgical protocols definitely reduces the recurrence and future outcome and of these patients with lethal malignancies, because what happens is that whenever there is a recurrence, there is a chance of these tumors and cancers de-differentiating into a severe variety of adenocarcinoma and polydifferentiated carcinoma, which in fact affects the patient's life. So neoadjuvant chemotherapy, as I told you, can be given in order to chemoreduce it to give a margin clearance, which can be surgically excised, and adjuvant treatment modalities when it's there are patient indication into it. Biologics is definitely there, but we do have challenges of biologics in India as far as costing is concerned and availability of the drugs are concerned. Thank you very much for your patient listening.
I just want to ask you a silly question. In one of your initial slide, you showed one patient with a hypermature cataract with an sebaceous gland carcinoma.
Yes.
Which one you will do first?
The cataract, sebaceous gland carcinoma, definitely
Not
first.
the hypermature cataract?
No, ma'am. I think it's a large tumor.
Because this is an issue. This
Yeah.
is a real issue. And hypermature cataract and the sebaceous gland carcinoma.
I would give preference for the carcinoma.
I will go on the reverse way. I will
You
do
will
the
go
cataract
reversal?
first. Let the
Okay.
patient see. Because the cataract will take just 1 day means to recover.
Okay.
And the carcinoma is waiting for a long time. We can wait. I will do that. I have done it.
It's a good question.
No, not that Pageau's spade. It was a well-defined lesion.
Yeah, ma'am, but it is in the tarsus. So any malignancy in the surface or the eyelid, when you're going for an open procedure over the surface, as an ocular oncologist, I would never take that risk. Never.
The patient will be blind then.
Never.
Okay.
So, ma'am, I'm always scared whether there can be intraocular
that's
extension of the tumor
So this
cells.
is always a controversy, like whether to go for the tumor or to go for the cataract. Only one thing is that sometimes anything which is in the surface, especially if it's a cancer, it needs to be treated, because one incident happened in one part of India where the tumor was operated first, followed by cataract, and later the patient came with endophthalmitis. And when they had done a biopsy, they found tumor cells in the vitreous. So it's always preferable to get rid of the cancer first and then to go for the cataract surgery.
Thank
But
you.
you're also right, ma'am. In a hypermature cataract, if it goes for Morgagnian and goes for a secondary glaucoma, that is also an emergency. But I think cancer should be treated first.
Okay, thank you.
Thank you.
Thank you, Dr. Feroz.
Thank you so much. We have Dr. Mukesh Sharma, who's here.
Welcome, Dr. Mukesh Sharma. He will be talking about posterior lamellar approach in ptosis surgery.
Good morning, everyone. Sorry for a little delay. Actually, my flight got delayed, and then I took inspiration from Feroz and just came running 400 meters from road to here, and I could at least enter in time. All right. So it's indeed a matter of pleasure speaking in front of your own teacher as well as student. I can, like Professor Mandeep Bajaj was my teacher, and Dr. Chandana, like she did her training when I was there as SR. So it's a great moment for me that way. So I shall be speaking today on posterior approach ptosis surgery. Posterior approach ptosis repair was described long back by Blaskowitz, probably in 1931. And what he did was levator muscle resection along with tarsectomy. Later on, many modifications came over the time. And there are three sets of established posterior approach ptosis surgery. One is Fasanella servet procedure. The second, which is the most commonly done surgery, is MMCR or Muller's muscle conjunctival resection. Then there are posterior approach levator procedures like levator resection from posterior approach or conjunctival approach, levator plication, and white line advancement from posterior approach. So primarily, I shall be discussing first two procedures because levator surgery is generally, I believe, is still most people are doing it from anterior approach because of some significant advantages. So for mild ptosis, procedure of choice, no doubt, is posterior approach. Here we do phenylephrine test. If phenylephrine test is positive, it means Muller's muscle is functional, then any surgery on Muller's muscle would be successful, and we aim to do MMCR in these cases. If phenylephrine test is negative, still we can do posterior approach surgery in form of Fasanella servet surgery, which is primarily a tarsoconjunctival resection, so this can be done. Levator resection is hardly done in mild ptosis. So how to do phenylephrine test? We all know it. Means still 2 drops of phenylephrine, varied concentrations are prescribed, 2.5 to 10%. After 5 minutes, we check for lid lift. If it is there, around 2 millimeter of lift, if it is there, maybe 1 to 1.5 millimeter also considered significant. It means that Muller's muscle is functional and MMCR can be successful. If ptosis is moderate, then again, nowadays, most people, including me, are doing MMCR. One can do levator resection or plication also, and in severe ptosis, there is no choice but to go for a sling. In exceptional cases, one can do the levator resection. So with this background, I'll be discussing few of the posterior approach procedures. Fasanella servet procedure. Classical indication is Horner syndrome, where you get 2 millimeter of ptosis and Muller's muscle is not functional. So here the results are excellent. Primarily, result comes due to excision of tarsus plate, and every 2 millimeter excision of tarsus plate will give rise to 1 millimeter of ptosis correction. So it is most predictable that way. Only disadvantage is that you cannot resect more than 4 mm of tarsus plate because you need to leave at least the equal amount of tarsus, that is 4 millimeter or so in upper lid for tarsal stability and lid stability. And this constitutes the disadvantage also because there are cases where you can have tarsus instability or entropion after some time, in few of the cases dry eye. So how to do this surgery? This is a gentleman with left eye ptosis, around 2.5 millimeter of ptosis is there. Eyes reverted back. We are doing a modification of traditional Fasanella servet. This modification was prescribed by our teacher, Dr. Batheria. So 3 stay sutures are passed on the tarsus edge. 4 millimeter is marked on tarsus. Then instead of clamp, what we are doing is we are again passing sutures which can retain tarsus as conjunctiva without occupying the space which tiny mosquito clamp generally occupies. So after making this line with your diathermy also, RF cautery, so that patient does not bleed too much. Yes. Then these 3 sets of retaining sutures are passed from conjunctiva to upper end of tarsus, which you need to resect. So once we resect out the tarsus, this can be done either through the scissors or through your RF cautery. So once you are through with this, now when you pull up these sutures, both the cut edges, they come together, and you don't need to struggle in suturing these 2 ends together. Classically described as plain catgut. Now we are not able to get it, so we are using 80 vicryl, but knot is typically kept outside on the skin. or it is buried inside so that cornea does not have any problem of knot exposure, not rubbing on the cornea. So one by one, these retaining sutures are removed and your inside suturing is completed. So this is the end of surgery. Very simple surgery done very fast. This is the external vicryl which is tied externally as we do it in MMCR. And final appearance after 1 week of surgery. Hardly there is any edema or so. So this is about MMCR result in both the eyes, Fasanella servate results. Both the eye Fasanella servate is done. In one eye, little less tarsus resection was done, and in other eye, a little more of tarsus resection was done. So the other procedure is MMCR. Here, instead of removal of tarsus, we remove primarily Muller's muscle and conjunctiva. Sometime a tiny strip of tarsus may additionally be removed to have augmentation of effect if ptosis is say 3.5 millimeter or so. So typically a clamp is used. These are pre-op and post-op. In right eye the surgery is done, 2 millimeter ptosis was there and beautifully corrected. So MMCR is first choice for most cases of mild to moderate ptosis with good levator function. Its advantages are that it's a fairly predictable surgery. It gives you reliable outcome without any skin scar, without any significant problem. Learning curve is less. Disadvantage is that sometimes you may end up with shortening of fornicial conjunctiva in patients who may require later on glaucoma surgery, may be of little problem, but nowadays conjunctiva sparing MMCR is done, so there you do not get conjunctival shortening. Also in severe ptosis, there is limitation of this surgery, the results are not that good. So this is how it is done. It's a child done under general anesthesia. You pass initial suture, holding suture, you word the lid. This is edge of tarsus, and since in this particular case ptosis was around 3.5 millimeter or so, so we had marked around I think 5 millimeter here. So in total the resection would be doubled. It will be around 10 to 11 millimeter of tissue which is resected, conjunctiva and molars. So we have made these marks permanent by applying few marks of cautery over there. Then the 3 holding sutures are passed, and here Putterman's clamp is applied. I'll be cutting around 1 millimeter of tarsus because of severity of ptosis. Then you apply again bipolar diathermy on the superior edge, so while resection they do not bleed too much. Now we are passing the pre-placed suture. What we use here is 6-prolene. So it is passed again from skin so that the knot is left on the skin, and this will be pulled out after say 8 days or so. Then in a running manner, this is passed. All over. And you have to leave allowance where you cut so that your sutures are not getting cut inadvertently. So in the end, you bring out again suture on the skin surface, then with the metal to metal contact so that your blade, it is away from the sutures. So the clamped margin is cut and your suture was there. It is just tightened up. Just for academic exercise, just to measure how much you have resected, the tissue is unfolded and measured. So it is that amount which initially we intended, and finally the knot is kept outside. So there are certain levator procedures also which can be done through posterior approach. Resection can be done, levator plication can be done, and white line advancement of levator can be done through posterior approach. But there is one distinct disadvantage, that you cannot combine these surgeries with skin muscle excision, which is needed in most levator procedures, or a limited blepharoplasty, one can say. So this is a huge disadvantage. That's why I personally do not prefer doing levator procedures from posterior surgery, because in my all unilateral cases, generally I tend to do little bit of skin muscle excision for a symmetrical lid fold. Also, in severe cases, you get some amount of limited exposure in comparison to skin surgery, but still yet you can reach up to the ligament from Whitnall's ligament from posterior approach also. So this is not a big problem, but this is a major disadvantage. So this is posterior approach levator surgery. So to conclude, there are many posterior lamellar options also for ptosis surgery, but MMCR stands out. It's a simple, predictable, relatively complication-free surgery, though it cannot be done in severe ptosis. We must always explain, as in any plastic case, realistic result to the patient. I believe in the philosophy of under-promising, over-delivering, so always say patient some guarded results, and if results are better, then patient will be happy. And side effects should always be explained to the patient. Thank you. Thank you for your patience hearing.
Thank you, Dr.
Mukesh,
Sharma.
I just want to ask you one thing, that in which cases do you prefer fascicular survet over MMCR?
Sir, only in those cases where the ptosis amount is quite less. If it is 1 to 1.5 millimeter ptosis only, then the predictability with MMCR is not that much. There are chances of overcorrection with MMCR, but with fascicular survet, you get absolute pinpoint predictability, 2 mm of resection, 1 mm of correction.
But
So
isn't it preferable to leave the tarsal plate alone and sort of just work on the conjunctiva?
yes, sir, but that's what the most people believe. What you are saying is right that way, but it does not harm actually. I have done more than 100 probably fascicular survet.
So
None of the
you
patients
didn't find any long-term problems like dry eye or entropion or anything?
Sir, it is described in textbook that there are chances of damaging minor salivary, minor lacrimal glands there, accessory lacrimal gland while you are resecting the tarsus, and there may be problem of dry eye. But I don't see that, and since I am leaving knot outside on the skin, so
right,
there are no problems of rubbing the knot.
Fair enough. Thank you.
Yeah.
Thank you, Dr. Mukesh. I invite Dr. Sumit Lahane for the next talk.
Thank you.
Dr. Mukesh, you can please take your chair on the dais.
Very good morning, everyone. So I'll be presenting three cases which were little dicey, and the presentation made us think that are we really on the track when we are treating them. I would like to ask questions to the panel in between my cases to understand the complexity, because many of them have not reached the conclusion yet. So this is the case 1, a 70-year-old female presented with the redness and photophobia, which is since 2 months, for which she was taking treatment from multiple doctors, and her vision best corrected was 666/36 with the grade 2 cataract. These are her clinical pictures, and if you see closely, this may not be very appreciable, but she had a palpable hard mass, almost 1.5 centimeter here in the lower fornical conjunctiva and the lower lid. We had our own differential diagnosis that it could be blepharoconjunctivitis or a severe conjunctivitis, and there was a discharge as well, and or the pituitary sebaceous gland carcinoma, which has been discussed. But patient was already taking antibiotic and the steroid topical combination from almost last 4 to 6 weeks, and there was no resolution of congestion, neither the part of the pain and the discomfort. So of course we went ahead with the biopsy. We did a map biopsy as well to understand what is it, and the histopathology confirmed it's an inflammatory lesion, which we did not believe primarily. We repeated the histopathology, and again it was an inflammatory lesion. Patient was treated with the oral steroids, and the whole course was settled down there itself, and the mass completely disappeared. So the take-home point here is a patient might present with certain mass which primarily could look neoplastic, but doing an incision biopsy always helps, and doing a map biopsy is not a harm if you are suspecting anything which can have a distant spread than the lesion being seen. The next case is a 25-year-old female. She presented with the drooping of the eyelid. Since 2 months, there was no history of trauma, and the vision was fine. There was very mild ptosis, but since there was only 2-month history, we decided to go ahead with all the workup, including myasthenia workup, and everything was negative, including the neostigmine test. Finally, on the demand of the patient, we decided to go ahead with the surgery, and patient was all good after 15 days. She was fine till 3 to 4 months. After that, she again started complaining there is some amount of drooping with which she was not happy. And again, we did the workup, everything was fine, and the lateral drooping slowly started increasing, and then we had to operate her again just to give her a cosmetic result, which again sustained for a period of time, but later on again it started drooping further. So I'd like to ask panel here that it's a unilateral ptosis, and despite of the uneventful surgery, there is a constant drooping. There is no blepharochalasis history or anything. So where are we going wrong, or what further we should do in this case? Dr. Leone, please.
Phenylephrine test.
Yes, sir, it was negative.
Negative.
Yeah.
Yes, in this case, I think even if you do a posterior approach and you resect the Miller's muscle, they get better.
The posterior approach in the second surgery you were suggesting?
You can do it even at the second time when you do it anteriorly. Then you can separate the aponeurosis from the malar muscle. You advance the levator muscle anteriorly, doing, a double layer. So you separate both aponeurosis and malar muscle from the conjunctiva. If you are more familiar with the anterior approach, they usually get better. Probably she has a very strong right dominant eye, and so you have to overcorrect ptosis on the table a little bit more.
The overcorrection in the posterior approach is the way to go. That's what you are saying, correct?
No, I say you can either choose the posterior approach and that's it, and you see how it works. If you're more familiar with the anterior approach and you have a drooping of the eyelid following primary surgery, then you advance both Miller's muscle and aponeurosis from the anterior approach, but you have to overcorrect on the table at least 2 to 3 millimeters. Probably these cases happen when you have a very strong right dominant eye in this case.
Correct.
You see, so ptosis is worse than you see.
Okay.
You know what I mean? You have to overcorrect it because it tends to do opposite.
Got it, to get the correction. Mukesh sir, since you had a talk on posterior surgeries, what is your experience with recorrection of your anterior approach with the posterior approach when there is a recurrence with the mild ptosis?
Well, it's functional, okay, fine. So I'll answer, I think, both comment on the first question also. If you are doing a skin approach, what kind of suture are you using for levator?
Sir, Proline, 60 Proline.
For levator, then it is fine actually. Sometimes we use vicryl for levator, and in some of the patients, the healing of levator is not proper and vicryl get dissolved. So if you are using non-absorbable, then that point goes away. So fine, coming to your question of resurgery with posterior approach, see, it depends who has done first surgery. If an accomplished oculoplasty surgeon has done first surgery, then we can think of doing resurgery because the adhesions would not be that much and resurgery will not be that problematic. But if first surgery is done by a novice, then sometimes the adhesions are too much to do proper, to get proper result in resurgery through posterior approach. But with MMCR, even if you are not able to dissect it properly and you are able to resect out the tissue with some fibers of levator with adhesions, results would be all right. But you'll have to check for fibrosis initially by injecting something subconjunctivally. If fibrosis is too much, things are bad, then go from anterior.
Good morning. I have an observation on your case, Dr. Sumit. I am Dr. Ajit. Did we try and look at the position of the right upper lid in the first time before you operated? It seemed to be a little more retracted rather than the ptosis of the left side. Secondly, the left eye has more inferior scleral show as compared to the right eye. So are we actually dealing with true ptosis?
So, ma'am, basically we had done the orthoptic evaluation as well with our.
Did you look at her thyroid levels?
They were normal, ma'am. Thyroid, and
Her anti-TPOs?
antibodies were
Diffusion-weighted imaging of her muscles?
that was not done, ma'am.
I think we need to have a keener look at this patient because it doesn't seem to be just a plain simple case of left upper lid ptosis.
Okay.
That's my opinion.
Fine.
Hi, I'm Dr. Ruchi Goel, and actually I had the same concerns. I would not have operated like just a 2 months history. I would have gone and done a more comprehensive workup for the patient first. And why do you think first, why did she develop the ptosis at all? One was, of course, because of the Hering's law, you had some kind of a picture which was not really a 2 millimeter ptosis. The retraction, in fact, if you go back to your previous picture and you can see there is some kind of a disproportion. So maybe we were not on the right track when we thought of doing a ptosis surgery in the first go. So whether it fails or it does not fail, that is a second question altogether. And did you evert the lid? Were there any other signs? Why did she develop an epineuritic ptosis? I think you supposed that it was an epineuritic ptosis. That's why you went ahead and did this.
Correct. Ma'am.
So what could you find the cause of epineuritic?
I could not find the cause, ma'am. That's why my primary diagnosis was myasthenia, then the aponeurotic. But since everything was negative and she never used contact lenses, no allergy, no rubbing, we could not find the cause.
So maybe I think the best course would have been to observe and do a better workup and then go ahead and do the surgery.
Okay, fine. Feroz ma'am, do you have a, can
I think we are done.
Okay, ma'am, I'll stop.
Nice
Okay,
case.
fine.
Thank you so much. Yeah. Regarding your first case, like the granulomatous lesion in the lower eyelid, we can have very bad MGD presenting like that. In fact, I had a patient similar case. We did an incision biopsy. He came with a lymph node also where there was so much of a suspicion of a malignancy. It came out to be a tuberculous granuloma, TB granuloma of the lower lid. So granulomatous lesion can also present like that. So as you rightly said, incision biopsy is definitely important because if you go for an excision where there is question mark, it's going to be a large excision without an evidence. Thank you so much.
Thank you, ma'am.
Similar to in your first case, I had a patient where actually there was fungal infection of the sinuses that presented in a manner. So, but you did the biopsy that can pick up both the things.
I recently had a case that looked completely like carcinoma, if you see per se, loss of lashes, nodular lesions, but she turned out to be lupus.
Oh.
On all 4 eyelids she had it. That was one reason to not suspect malignancy as the primary diagnosis. So we went ahead with an incision biopsy. It turned out to be lupus.
Yeah. I think one important finding may be the widening of lash margin. In malignancy, the margin got widened up, orifice of meibomian gland and eyelashes, that distance increases typically. And if we are dealing with the pagetoid kind of spread where there is no nodule and there is confusion with blepharitis, but in inflammatory, you don't get that typical widening of margin. In your case also, it was not there.
Correct.
So I think that is one clinching point.
Thank you so much. With this, we come to the conclusion of the eyelid session of the Oculoplasty module. Thank you so much, Dr. Neha, for moderating, Dr. Sharma, Dr. Chandana, Dr. Bajaj, and Dr. Francis.